Dear colleagues, thank you very much for inviting me to join this new Laser Society, and I'm very happy to be the part of this project. Today I would like to share my views and my experience with subthreshold micropulse laser in central serous chororetinopathy. We know that the classification and approach to that disease has changed just recently, and we have to adapt to this new situation and also to confront with our methods of treatment. Let's start from the disease characteristics. We know that it's quite a common disorder which occurs predominantly in young individuals, usually between 20 and 50 years of age, with definitely more prevalence in males, with the proportion approximately 3:1. We know, and that's the most important from the pathogenesis of the disease, is that it's a part of the pachychoroid spectrum of diseases, which results in dilation of large choroidal vessels and pressure on choriocapillaries. We also know from the course and the experience with the course of that disease that it spontaneously resolves in majority of cases. Our colleagues from Spain report that it's about 84% of cases resolve spontaneously. However, it can proceed to the chronic form in this 16-15% of cases. We know that CSCR cannot be treated as a light disease, not only self-limiting, but in certain percentage of cases it can result in significant impairment of vision. It usually is attributed to chronic cases. However, I also experienced some acute cases, short-standing cases that end up with very poor vision. Important fact is also that it's complicated by the CNV or MNV, as according to the new classifications. With the NGO-CT employment, we know that this percentage is quite high. It's sometimes given even as close to 40% in some research. What are our questions and dilemmas when we speak about this disease? As I said, the classification, the traditional classification is acute versus chronic, with the division of the time point between 4 and 6 months. But nowadays we tend to call those types of CSCR as simple versus complex, basing mainly on autofluorescence image. The dilemmas also apply to the timing of application of treatment. We are used for many years to wait for spontaneous resolution of symptoms. However, I personally favor prompt treatment. We also have to determine what kind of treatment should be administered when we consider the morphology of the disease. And this is mainly the question or the choice between the subthreshold micropulse laser or PDT. Then we have different protocols of subthreshold micropulse. We use yellow laser or infrared laser 577 versus 810. We also treat different areas of retina, so we sometimes use minimal or panmacular treatment. Then we do not also have very precise retreatment criteria for subthreshold micropulse. So I try to talk about those aspects of this disease, of the morphology and also treatment. So as I said, the traditional classification is acute versus chronic. Acute cases are characterized by subretinal fluid, usually without any other complications, very few PEDs. It usually resolves spontaneously within 3 to 4 months. Chronic cases have present with a variety of different morphological aspects, features, like alterations of RPE, hyperpigmentations, RPE atrophies, also cystoid changes in the neurosensory retina. We also see fibrin in subretinal fluid or bullous subretinal detachment. Jay Chablani will talk about photodynamic therapy, but he's also one of the authors of this new classifications of CSCR, which in my opinion is a milestone in our approach to CSCR recognition as a complex or simple disease. Well, this paper published in Ophthalmology, less than 2 years ago, defines major diagnostic criteria, which we all know that it's the presence or evidence of prior subretinal detachment documented on OCT, and also presence of at least one area of alteration of the RPE, and minor diagnostic criteria which refer to the picture of fluorescein angiography or ICGA, but also subfoveal choroidal thickness, which in CSCR is quite enlarged, more than 400 micrometers. However, we have to consider the axial length and age in that respect. So, to cut the long story short, we treat the CSCR cases as simple or complex, basing on the total area of RP alterations, which are best detected on autofluorescence. So if those areas are less than these areas, then we treat the disease as simple. If the area is larger, then we treat it as complex. And that, in my opinion, also should implicate our preference of treatment with the shift towards PDT, in my opinion. However, it has to be conferred on larger trials for sure. We have different therapeutic options. We, as I said, for many years observed those cases for 3 to 4 months or even 6 months, waiting for spontaneous resolutions. But this is mainly due to the fact that we didn't have non-damaging retinal therapies like subthreshold micropulse or TruRT laser. Let's say 2 or 3 decades ago. Nowadays, we have those means of treatment, so we have changed our approach. Different conservative therapies were tried, like low doses of aspirin, non-steroid anti-inflammatory drugs, antibiotics, but without confirmation in larger studies. Mineralocorticoid inhibitors, preferably eplerenone, were tried in many clinical trials, but still I think that there is no consent on this therapy. There are researchers who advocate and who see its efficacy, while others do not. Anti-VEGF was tried in many cases, but I think we all agree that it's effective in cases complicated with choroidal neovascularization, but not in simple cases. Then PDT was tried for many years, especially in the Far East, and we have very good experience with that when we know that both approaches with half dose or half fluence are effective. Classic focal laser photocoagulation was the main form of treatment of chronic cases, as I said, 3 or 4 decades ago, when it was practically the only invasive option. And it was applied in selected cases when the leakage point was located in the safe distance from the foveal center. Nowadays we have subthreshold micropulse, which is, I believe, our main point of interest, but also other non-damaging techniques like endpoint management, which is very similar in its philosophy to SML, but also nanosecond lasers or microsecond lasers like TruRT or SRT. Well, it's worth, in my opinion, to recall some of the treatment recommendations formulated by GAS that refer to classic laser photocoagulations. At that time, when it was first episode of CSCR, it was recommended to wait for at least 4 months for spontaneous remission. And then if that remission did not occur, then the LPC was permitted in selected cases with the safe location of the leakage point from the foveal center. Why I'm talking about it now? Because nowadays when we talk about the retreatment criteria of subliminal laser, we also copy the same approach. In that approach, the repetition of the laser session was permitted after 3 to 6 months. And as our knowledge is probably not yet that deep, we also copied that protocol. However, I do not strongly agree with that. I think that we can perform the second session of SML earlier if we have no reaction or reduction of subretinal fluid. What are the results of subthreshold micropulse in CSCR in clinical trials? There were many, so I'll just sum up those results. Total resorption of SRF is reported in 40 to 80% of cases. In our cohort of patients, it was quite a large cohort, 51. We achieved total resolution of subretinal fluid in 70%. However, as mainly chronic cases are treated, the improvement in best corrected visual acuity is not spectacular. It's usually 0.1 logmar or 1 line on a Snellen chart. And that's a common feature of the results of different clinical trials. We see that better functional results are achieved with early application of subliminal laser, and it's not only our study but also colleagues from Barbados, for example, that prove that early application of subliminal laser can result in better functional results. This is a summary of, let's say, meta-analysis of our friend from Germany. She showed that the different morphological and functional, let's say, results of SML treatment in different diseases. When you look at the top line with CSC, the improvement in BCVA is about 6 letters after the last letters, which is approximately 1 line. However, we have to look at the range. The range from those many studies combined together is from -15 to +20. So it means that really specific criteria should be applied to wisely apply SML. When we look at different protocols for SML, both 577 and 810 lasers are used without any significant difference in effects. What's common with the protocols? The common is duty cycle, which is empirically set at 5%. However, spot diameter, pulse duration, power can be adjusted when we calculate fluence, which is energy per area. What is a little bit controversial is the treatment area, because some of the researchers use minimal treatment, which targets just the leakage point. Myself, for a certain period of time, used SDOCT based treatment, so I covered the whole area of subretinal fluid presence based on the map of OCT. However, my colleagues prefer panmacular treatment, which is treating the area within the arcades, the whole area of the posterior pole, to mobilize the vast number of RPE cells. There's also controversy between transfoveal or fovea sparing protocol. Well, I have nothing against treating fovea, and let's say most of the patients treat transfoveally. Big controversy is the adjustment of laser power, because some of the researchers use fixed parameters, some of the researchers titrate. I prefer fixed parameters, to be honest, and I didn't see any significant difference between the results of application of fixed parameters or titration. Then I can give you also a few examples of different protocols for 577 or 810 laser that I used. As I said, it's all question of calculating the fluence, so there are no significant differences between the results of those protocols. When we talk about retreatment criteria, well, different, let's say, intervals are used between the laser set sessions. So as I said, we sometimes copy the recommendations of GAS, which refer to LPC. And that means that we wait for at least 3 months between the following session of subliminal laser. However, in the study with my colleagues, with Jeffrey Lutru and Igor Kozak, we use different approach, and I think it's reasonable. We checked the patients on the OCT after 6 weeks after the first session, and if we didn't have any reduction of subretinal fluid, we performed the second session after 6 weeks. If the reduction was observed, then we waited and we performed another OCT measurement at 3 months after treatment. And if the fluid was still present at that time, we repeated the treatment. So this is, I think, quite reasonable approach. The big, I think, discussion is worth it's worth discussing the timing of SML application in acute versus chronic cases. Most of researchers agree that chronic cases should be treated, but I believe that as we have non-damaging retinal therapies, there is no use to wait in acute cases if we really do not really know whether this acute case will not become chronic. So when we look at the amount of damage in the course of CSCR, we see that it can be quite significant, and this is confirmed by different studies by colleagues from Netherlands or by colleagues from States. We see that quite a lot of patients can end up legally blind with these chronic cases. So we really should aim to prevent that. This is the picture that we quite often see in chronic cases when we think that the treatment was successful, the subretinal fluid resolved. However, we have significant retinal thinning in the center. Well, in our study that we performed 2 or 3 years ago, we also observed the areas of the signal void on OCT angiography, and I think that explains the retinal thinning and the loss of nutrition to photoreceptors, and in consequence loss of photoreceptors and loss of vision. What's interesting, some authors also report visual impairment after resolved acute cases of central seros. So that's also, in my opinion, should incline us to treat early. And we also performed our study. When we checked this, we performed transfoveal micropulse laser treatment of CSCR in cases of duration shorter than 6 months. And then we tried to find a correlation between the application of treatment and the functional effect. We checked the best corrected visual acuity, SOCT, and so on, and the application of subliminal laser was different in different cases. So what we achieved is a very, very strong correlation. We see it here between final best corrected visual acuity and timing of application of subliminal laser. The patients treated early gained more letters or gained more lines on the chart. This result was also achieved or presented by Dr. Aurora from Barbados. It was a randomized clinical trial of SML in acute CSCR versus observations, or cases that were observed ended up with worse final visual acuity and worse contrast sensitivity. Well, I will not talk about PDT because that's what Jay Chablani is going to talk about. However, I just want to highlight that we have very good experience with that treatment modality. We have high percentage of resolution of subretinal fluid, and also, what's interesting, quite low number of recurrences. I would like to end up with an interesting case that I approached, which gave me lots of thoughts, because it's a very young person with who experienced CSCR in both eyes. Well, I saw him after the first episode, which was treated in a different center, was treated with classic laser photocoagulation, and after relatively short period of subretinal fluid presence, for about 5 to 6 months, this young person ended up with the final visual acuity at 0.1 on Snellen chart. Unfortunately, when he came to my center, well, I treated him on the spot, having this experience. I mean, being acknowledged about this experience from his first eye affected, and I treated him with subthreshold subliminal laser, and finally PDT with the quite poor final functional effect of 0.1 again. But let's have a look how it looked. Well, the left eye was the eye that was treated by our center. Here is the spot after laser photocoagulation, and here's the right eye that I treated at presentation. So I started with subliminal laser. I performed, I believe, 2 sessions with both 577 and 810, because I'm using both. And it didn't work. This is his fundus autofluorescence after the PDT. We see that the area of these alterations is quite large. However, it didn't look that bad on the OCT. Here we see this is the scan at presentation, then these unsuccessful sessions of subliminal laser, and finally PDT. But after PDT, as we see, significant retinal thinning after, let's say, 5 months of the subretinal fluid presence. I also checked his MRI, whether he doesn't have, let's say, any neurological disease. No, nothing was discovered. And here is the other eye, also with significant retinal thinning. And it gives me a thought. Maybe if I treated him with the PDT as a first line, maybe he would have a better chance. I don't know. This is the question to discuss. So to end up this short presentation, I would like to highlight some of my conclusions, but also the questions that we as a group probably should answer and discuss. So I believe that evaluation of the CSCR type in the context of morphology is crucial for decision making in treatment. I believe that long-standing and complex cases should be treated without any delay. Then, should we promptly or defer treatment in acute cases? I favor prompt treatment. However, more randomized research is needed for sure. When we think about subliminal laser, it's cheap, it's very simple, it's comfortable for the patient, so that favors this form of treatment as a first-line therapy. However, I strongly believe that we still have to define the patient that would favor from subliminal laser and not from the PDT as a first line. Then we also have to decide how many sessions should we apply of laser, subliminal laser should we apply before switching to PDT. Again, define the cases where PDT should be the first line of treatment. I believe Jay Chablani will talk about also. Thank you very much for your attention, and thank you again for being the part of that great society. Thank you.